We are AM Surgical, and this is AM Innovation.
Carpal tunnel is one of the most common nerve problems that any hand surgeon sees. Most of the time it can be treated conservatively with splinting, activity modification, or even carpal tunnel steroid injections. I look at carpal tunnel as a spectrum from moderate and early disease where symptoms are intermittent and there's no weakness, and that can be treated conservatively, injections, therapy, splinting, and then people who have severe disease. So these are people with constant symptoms, have atrophy or denervation. The nerve compression is so bad that they're actually losing function and the nerve is dying. And those patients, I recommend taking the pressure off the nerve. I don't inject those or treat them conservatively because it's somewhat time sensitive. There's two ways to do carpal tunnel surgery, open and endoscopic. I did open for 15 years, and over the last 5 years I've been doing it endoscopically. I found that endoscopic is associated with much less pain and a much earlier recovery. So I generally favor endoscopic. Actually, I started to develop a little bit of carpal tunnel syndrome myself, and I thought, what would I want if I was going to have it done? So that sort of pushed me to start investigating, and I started doing endoscopic carpal tunnels with Stratos. And very quickly, I saw a real difference in patient satisfaction and early return to work and less pain post-op. The process that I used to switch from open to endoscopic was I did a cadaver lab, and I remember the visualization, not of what we were seeing, it was just a little bit foggy, and you had said, oh, when you do this in a human, the visualization is better. And I said, this guy is full of it. That's not true. And actually, having done a few cadaver labs and taught them, it's 100% true. The visualization in a live human is much easier. So I did a cadaver lab, and it seemed very easy, very straightforward. And then I started booking some of them, but there was a time gap between when I did that first lab and the first one came. So Stratos was great. I did a cadaver lab, or did one specimen the night before, and then I rolled right into it. And it really was not an issue. I think also what helped me was I watched a few of the videos of another surgeon, just the video, just to sort of get a little sense of how they did it. If you're interested in doing or learning how to do an endoscopic carpal tunnel, I do an endoscopic carpal tunnel lab in proximity to your scheduled case. I think the support of the Stratos team is great. They're literally staring at the screen with you if they're in the OR during that first case, so they're very helpful. What I like about the Stratos device is the clear cannula. I like that I can see both radially, ulnarly, and deep. I like that it's static. I know that if I have a perfect clear runway and I'm levered up against the transverse carpal ligament, I'm not worried about having any type of injury. I feel very confident in that. People told me that you got to be prepared that if you can't see what you want to see, you may need to open. So I counsel every patient that if I don't get visualization the way I like, that I may have to open. I don't even know how many I've done now, but I've never actually opened one. I make a transverse incision at the wrist flexion crease. I expose the forearm fascia. I incise that, being careful to protect the nerve, which is right under it. I release the forearm fascia proximally. I use a freer to scrape any tenosynovium off the undersurface. And then I put the cannula underneath, and I literally just put it right underneath, and I kind of lever it against the transverse carpal ligament so that it's literally pushing any tenosynovium or any structures out of the field. I push it to the end till I see a fat pad. I deploy the blade. I release it. At the very end, I release it millimeter by millimeter, and I push the clear cannula a little forward to push any of the structures distally out of the way. Once I'm comfortable that the full release is done, I put the blade away. I look radially. I take a picture of the radial leaflet cut. I look at the median nerve. I look to see if there's an extra ligamentous motor branch that I can see. I look ulnarly, look at the ulnar leaflet, look at the flexor tendons. I pull the cannula out. I look visually to make sure there aren't any fibrous bands distally or proximally that aren't released. And then I personally close with 3 inverted figure of 8 5/0 nylon, a single parallel steri-strip, and a soft bandage that they take off 5 or 6 days later. It's very safe and very effective. Like anything else, the setup, there's a little bit more equipment. So for me, I have 2 rooms, so I usually do a bunch of these in any given day, so I'll put the endoscopics in one room, so they just follow each other. But the OR staff gets very used to it, and the time difference is really not that much different than an open. Maybe it's a minute or two, maybe more at this point. But for me, what I love is, the way I close and the way I just tell the patient take the bandage off 6 or 7 days later. Most of these patients are doing a lot of them are doing their other side 2 weeks later. So I say, take your bandage off 5 or 6 days later, and then I see them for their post-op when I'm doing the other side. And what's been shocking to me is some of these patients are elderly people that live alone, which you're very reluctant to do that in an open because sometimes they can have pain, they have to care for themselves, and I just have not found that. So I tell them if they want to proceed to their other side in 2 weeks, just let me know. And the amount of elderly people that are comfortable with that, because it's really not that painful and they're functional and the incision's not in their palm, it's been remarkable. Most people don't take any pain medicine other than Tylenol or Advil on the first night or two. I've done enough now over the last 5 years that it's a very glaringly obvious improvement in technique and technology, and I've been thrilled, and I'll never go back.
We are AM Surgical, and this is AM Innovation.